Hello students. So let us discuss a new topic, and that topic is known as the core strengthening and the stabilization in therapeutic exercise. So we are going to look about what is the core, how the core muscles are organized, and how much importance is core strengthening and stability in therapeutic exercise. So first the question is, what is the core? To know the core, we have to know about the lumbopelvic hip complex and the location of the center of the cavity, COG. And for an efficient core, there should be, or an efficient core allows for the maintenance of normal length-tension relationships. It allows the maintenance of normal force couples, maintenance of optimal arthrokinematics. It allows the optimal efficiency in the entire kinetic chain during the movement, like acceleration, during deceleration, during dynamic stabilization, and it allows the proximal stability for movements of the extremities. So if you look at the functional anatomy, there is about 29 muscles attached to the core. The lumbar spine muscles, the transversospinalis group, the rotators, the interspinalis, intertransversi, semispinalis, multifidus, erector spinae, the iliocostalis, longissimus spinalis, quadratus lumborum, latissimus dorsi. So you can see there are many muscles layered over and which are attached to the spine, which acts as the stabilizers. So we can divide the muscles into the stabilizers and the movers. So some muscles the body, the brain require for movement, and the other muscles the brain require for stability. So the core muscles fall into the group of stability, in stabilizing the spine and stabilizing the movement. So the transversospinalis group, it has a poor mechanical advantage relative to movement production. Primary type 1 muscle fibers with high degree of muscle spindles is optimal for providing proprioceptive information to the central nervous system. Intrasegmental stabilization. The erector spinae provides intersegmental stabilization, eccentrically decelerate the trunk flexion and rotation. Quadratus lumborum, it is a frontal plane stabilizer, works in conjunction with gluteus medius and TFL. And the latissimus dorsi bridges between the upper extremities and the core. Now the other group of the core is the abdominal muscles, the rectus abdominis, external obliquus, internal obliquus, transverse abdominis, which work together to optimize the spinal mechanics, which provides sagittal, frontal and transverse plane stabilization. Also, the hip musculature is very important because the hip is the junction between the upper trunk and the lower extremities. So the core muscles are attached here and the hip is closely associated. The psoas major muscle works in the closed chain versus open chain functioning. It works with erector spinae multifidus and deep abdominal wall. It works to balance anterior shear forces of the lumbar spine. It can reciprocally inhibit gluteus maximus, multifidus, deep erector spinae, internal oblique and transverse abdominis when tight extensor mechanism is in dysfunction. It works synergistically in dominance during hip extension, like the hamstrings and the superficial erector spinae. It may alter the gluteus maximus function, altering hip rotation in the gait cycle. Gluteus medius, it is a frontal plane stabilizer, and its weakness increases frontally and transverse plane stresses because of the patellofemoral stresses. It controls femoral adduction and internal rotation. Its weakness results in synergistic dominance of the TFL and quadratus lumborum. Now the gluteus maximus, it is main for the hip extension and external rotation during the open kinetic chain. Concentrically, eccentrically hip flexion and internal rotation takes place. Decelerates tibial Internal rotation with TFL stabilizes the SI joint, and faulty firing results in decreased pelvic stability and neuromuscular control. Now coming to the hamstrings, it concentrically flex the knee and extend the hip, rotate the tibia, eccentrically decelerate knee extension, hip flexion and tibial rotation, and works synergistically with the ACL to stabilize tibial translation. All these muscles produce and control forces in multiple planes. Now the core functions and operates as an integrated unit. The entire kinetic chain operates synergistically to produce force, reduce force and dynamically stabilize against abnormal forces. In an efficient state, the core enables each of the structural components to operate optimally through distribution of weight, absorption of force, transfer of ground reaction forces. So it requires a good training for optimal functioning of the core, and in the training the entire kinetic chain is trained on all levels in all planes. Now also the neuromuscular efficiency is very much important in training of the core. Now when we talk about neuromuscular efficiency, that means the ability of the CNS to allow agonist, antagonist, synergist, stabilizers, neutralizers to work efficiently and interdependently. It is established by a combination of postural alignment and stability strength. It optimizes body's ability to generate and adapt to forces. The dynamic stabilization is critical for optimal neuromuscular efficiency. So the rehab generally focuses on isolated single plane strength gains in the single muscles. Functional activities are multiplanar, requiring acceleration and stabilization. The inefficiency results in body's inability to respond to demands. It can result in repetitive microtrauma, faulty biomechanics, and injury. Compensatory actions also result. Now, what is the core stabilization concept? A specific core strengthening program can improve dynamic postural control, ensure appropriate muscular balance and joint arthrokinematics in the lumbopelvic hip complex. It allows for expression of dynamic functional performance throughout the entire kinetic chain. It increases neuromuscular efficiency throughout the entire body. The spinal stabilization is equally important. It must effectively utilize the strength, the power, neuromuscular control, and endurance of the prime movers. If there is a weak core, there is a decreased force production and decreased efficiency. The protective mechanism for the spine decreases if there is a weak core. So the spinal stabilization exercises act as a protective mechanism for the spine. It facilitates balanced muscular functioning of the entire kinetic chain, and it enhances neuromuscular control to provide a more efficient body positioning. So we have to equally give importance to postural considerations like the core functions to maintain a postural alignment and dynamic postural equilibrium. So optimal alignment is equivalent to optimal functional training and rehabilitation. Segmental deficits results in predictable dysfunction in a serial distortion patterns. Structural integrity of the body is compromised due to malalignment. Abnormal forces are distributed above and below the misaligned segment. What are the neuromuscular considerations? It enhances dynamic postural control with strong stable core. The kinetic chain imbalances, which is equivalent to deficit in neuromuscular control. So the impact of low back pain on the neuromuscular control, joint ligament injury, neuromuscular deficits, resulting in neuromuscular deficits. The arthrokinetic reflex, it's mediated by the joint receptor activity. The altered arthrokinematic reflex can result in arthrogenic muscle inhibition and the disrupted muscle function due to the altered joint functioning. So how do you assess the core? The assessment of the core, you have to check for the muscle imbalances, the arthrokinematic deficits, the strength, endurance, neuromuscular control, and power of the core muscles, overall functioning of the lower extremity kinetic chain. To assess the core, there is a method like the straight leg lowering test. The patient is in supine with the knees in extension. A BP cuff is placed under the lumbar spine, mainly in under L4, L5, and raised to 40 mm mercury. With knees extended, then the hips to 90 degree. We ask the patient to take the hips to 90 degree. Performs drawing in maneuver, that is drawing of the belly button to the spine. You have to contract the belly button to the spine and contract the core muscles, and then flatten back maximally into the table, into the BP cuff. Then we ask the patient to lower the legs to the table while maintaining a flat back, and the hip angle is measured with goniometer. Abdominal neuromuscular control test. Patient supine in knees and hips in 90. BP cuff placed under the lumbar spine L4 L5 raised to 40 mm mercury. Performs again the same drawing in maneuver, the belly button to spine. Lowers the leg until pressure decreases. It assesses the lumbar spine moving into extension, ability of the lower abs wall to preferentially stabilize the lumbopelvic hip complex. The hip flexors begin to work now as stabilizers. It increases anterior shear forces and compressive forces at L4 L5, inhibits transverse abdominis, internal oblique, and multifidus. So the core muscular endurance and power. Endurance, the erector spinae performance is the important factor. Prone with hands behind and head and spine extended 30 degree. To measure the ability to sustain the position with goniometer, utilize the axilla and table for frame for reference. Hold and maintain as long as the person can. Power, backwards, overhead medicine ball, jump and throw, assessment of total body, power production. So this is for the endurance and this is for the power measurement. Lower extremity functional profiles, you have to go for the isokinetic tests, balance test, jump tests, power test, sport specific functional tests. The kinetic chain assessment must assess all areas of potential deficiency. Now there are certain guidelines for core stabilization training. We have to perform a comprehensive evaluation of the muscle imbalances, myokinematic deficits, arthrokinematic deficits, core strength, neuromuscular control, power, overall kinetic chain function. The muscle imbalances and arthrokinematic deficits must be corrected prior to engage or to initiate aggressive training. The program requirements is systematic, progressive, and functional. It emphasizes muscle contraction spectrum, that is the concentric force production, eccentric force reduction, isometric dynamic stabilization. The program begin in most challenging environment that can be controlled. It must be challenging with progression through function continuum. The program variation must be there: plane of motion, range of motion, loading, physio ball, medicine ball, body blade, weight, vest, tubing, body position, amount of control and the speed, the feedback, the duration, frequency, like the sets, repetitions, time under tension. There are some other specific guidelines for the exercise selection. Proprioceptively, it should be a rich program of exercise. It should be safe. It should be challenging. It should stress in multiple planes. It should incorporate a multi-sensory environment. It should be again activity specific. Progressive functional continuums like slow to fast, simple to complex, known to unknown, low force to high force, eyes open to eyes closed, static to dynamic. The goal of the program is to develop optimal levels of the functional strength and stabilization, to focus on neural adaptation instead of absolute strength gains, increase proprioceptive demands. We should focus on quality, not the quantity. So poor technique and neuromuscular control results in poor patterns and stabilization. Focus should be on the function. So in designing and this training program, when you engage, you should ask some questions to yourself to evaluate that you are going for the right training program. Like, is it dynamic, is it multiplanar, is it multidimensional, is it proprioceptively enriched, is it systematic, is it progressive, is it activity specific, is it based on functional anatomy and science. So this is the exercises, some of the exercises in level 1, that is for stabilization, the core stabilization training program. The belly button drawing in, the bridging, the um, knees and hands exercises, the planks, side planks, hands on elbow, the Superman exercises, the oblique sit-ups, and then the other exercises as you can see here. Level 2 is the stabilization plus strength. So here we increase the level of exercises in plane wise, in activity wise, in slow to fast, or uh, from easy to difficult. So you can see we use some medicine balls, gym balls, where you have to control the core. Also you have to engage the neuromuscular coordination. These are the progressions. And then level 3 is integrated stabilization and strength. Here jumping with the medicine balls and the gym balls, squatting and standing, planks on gym balls, push-ups on gym balls. These are slowly increased and as the strength improves. So this is the integrated stabilization and strength. This is level 4, which is difficulty level increases further, and it is called the explosive stabilization, where you have to do activities of jumping, throwing overhead the medicine ball, passing the medicine ball, or this will improve your core, your stability, neuromuscular function. This is the level 4, which is known as the explosive stabilization. So that was about a basic idea of effective core and core strengthening and stabilization program. And as a physios, if we are going to design this rehab program or the core stability program for any person or any patient, then you have to keep these basic guidelines and basic factors in your mind in designing the program. These are the few references from which I have taken. So I hope this video will be helpful for you to understand the principles of core stability and the stabilization designing program. So thank you for watching this video.